Okay, so our next panel is on mental health services and programs with Karen Baylor, who we've already heard reference to several times, Deputy Director of the DHCS's Mental Health Substance Use Disorder. Terry Rooney from Colusa County, Behavioral Health Director, Behavioral Health Directors Association, and Dr. Stuart Teal, Clinical Professor of Child Psychiatry at UC Davis. And perhaps I should preface before we start this panel that this is of particular interest because my clinical specialty has been children with behavioral problems and learning disabilities. And so I worked very closely as a school physician on children who had challenges in school and with behavior. So obviously an area of very deep interest for myself personally, and I appreciate all of you being here. And actually, Ms. Baylor, do you want, can you?
Sure, I can start. Thank you so much. It's a pleasure to be here. With the implementation of the Affordable Care Act, we were able to expand mental health services for the mild to moderate under the managed care plans. What I oversee is specialty mental health, and so that's what I'm going to talk about today. So, as you know, DHCS is the single state agency for Medi-Cal, and through the authority of a 1915B Freedom of Choice waiver, we contract with all of the counties to provide the specialty mental health services. I'm going to list off just some examples of some services, and hopefully my county counterpart here can provide more in-depth detail. But when we consider mental health services, we're talking about individual, group, assessment, plan development, medication support, psychiatric support, crisis intervention, crisis stabilization, EPSDT, which we just talked a little bit about, and targeted case management in psychiatric inpatient. But keep in mind that these are not just office-based services, that a number of these services we're able to provide, or the counties provide out in the communities. As I mentioned before, EPSDT is available to those who have Medi-Cal under the age of 21, and the counties are required to provide a range for the provision of the specialty mental health services who meet medical necessity criteria. DHCS's role and responsibility is to provide oversight and monitoring of the mental health plans, and we do that through an annual external quality review that goes out and reviews each county plan once a year, and then we do a triennial where we look at the whole system, and then we also do chart reviews. You mentioned earlier some questions about dashboards, and I just wanted to mention with the recent 1915B approval from CMS, they granted us, for the first time, a 5-year approval, which we were very excited about, but they had requirements, one of which would be that we develop dashboards at the state level, but also at a county level, and we're working on those right now. But hopefully, within the near future, we'll be able to have dashboards where people can go onto the website and be able to see what counties are doing. Regarding funding, there's a number of funding streams that all go into a big pot in the local level, and then there are local decisions made as to what is in the best interest of those communities and how they spend those dollars. And I'm just going to give you a brief highlight of some of that funding, one of which is 2011 realignment, which established a behavioral health sub-account that goes for EPSDT, specialty mental health, drug Medi-Cal, and other substance use disorder services. So it all goes into one big bucket, and then on the local level, they decide how to spend those dollars. There's the Mental Health Services Act, which was Prop 63, which is the 1% tax on billionaires. 1991 realignment, which is a percentage of sales tax revenue and vehicle license fee that goes into the local account. And then there is the federal financial participation, which of course is the federal piece of that, and the county general funds. On the local level, you use that all of those funding streams to braid it and leverage it and to expand to make sure that you are providing the services that you need on the local level. Regarding coordination with other agencies, we do a lot with our sister agency, the Department of Social Services, on a number of issues regarding foster care and the use of psychotropics. We have been working with the Oversight and Accountability Commission on their crisis services work group. We're involved with the Child Welfare Council and others on the Priority Access Project, which is looking at families for reunification. We work with the Office of Juvenile Justice and Delinquency Prevention and the Attorney General's Office on the Defending Childhood Initiative, and I have a whole list of others, but those are the highlights.
Excellent, thank you. And hopefully, if you want to provide the list to our staff, that'd be wonderful. So, thank you. Mr. Rooney, welcome.
Yes, good afternoon. I'm Terry Rooney. I'm the Behavioral Health Director in Colusa County. I'm also representing County Behavioral Health Directors Association. I'm the co-chair of the Children's Systems of Care Committee. I'm also a licensed clinical psychologist with a specialty in child psychology. A 30-year advocate, Dr. Rooney, yes, thank you, and Dr. Baylor.
Dr. Pan.
That's quite all right. We're pretty familiar. But more importantly, I am a 30-year advocate for child services and the parent of a child with special needs. So as Dr. Baylor had indicated earlier, the county contracts with the state to provide the specialty mental health services, which include individual group services, services in the community, school-based services, medication services, crisis services, et cetera, whatever is we are the safety net. We provide the services at the local level. Happy to expound on any of those if you have any particular questions. I think part 2 was about what are the current challenges and barriers. Are we there yet, or? Okay. I just wanted to highlight a couple of things. Somewhat ironically, one of the challenges in the North State has to do with the managed care entities and their inability to provide provider networks in our area. So we continue to be the providers of services, even though, dare I say, they've already been paid to provide those services in a capitated system. We, in a fee-for-service system, continue to provide those services because the providers are simply not there. So primarily psychiatric services, but also all of the other specialty mental health services. And the threshold of medical necessity being fairly low for children, that means all the mild to moderates. That means anything from basic socialization, school services, all the way to crisis services for children who are in need of hospitalization. Another
Actually, a quick question. Sorry, I'm going to do all the questions at the end, but just to clarify, the managed care entities you're referring to, are those the Medi-Cal managed care plans?
That is correct.
Okay.
And I can't speak for the entire state, but I do belong to a consortium for the northern state, the Superior region, and we have in our region 2 entities. We have Anthem Blue Cross and California Health and Wellness. And although I appreciate the challenges associated with designing those provider networks, it still at this point in time falls to us. And so that, to me, constitutes a large challenge. The other challenge that I would like to bring some attention to is congregate care reform. And again, as I mentioned earlier, as a 30-year child advocate, I've been advocating for group home reform for many, many years. I'm pleased to see that it's happening, but I'm concerned about the dependency of that reform in actuality on mental health services. It will create an increased demand for those services, especially the higher end services on a local level and a regional level and on a statewide level that I don't feel that we're currently prepared to offer. Our mandate is always the least restrictive environment. So we always try and engage people in the community, in the home. And for these children who have traditionally had higher levels of care, supporting them in the community is going to be challenging. Thank you.
Thank you. Finally, Dr. Teal, welcome.
Hi. I'm Stuart Teal. I'm clinical professor of child psychiatry at University of California at Davis. More important, though, I've worked in a community mental health center in North Sacramento for 40 plus years. I was in charge of children's mental health services for Sacramento County in the early 70s. We got all the kids out of the state hospital and try to get them into facilities that could accommodate their needs. I'm afraid we didn't do that for all of them. Child psychiatry provides services other than handing out medication. What a child psychiatrist does at a community mental health center is, first of all, a good evaluation. It's crucial. Then you work as a team with the child having a therapist. If the child needs medication, the child psychiatrist will provide it. If the child needs other kinds of services, you'll try to make them happen. For example, I had a child that I thought needed an EEG for a potential seizure disorder. It took me 6 months trying to get the HMO to provide that EEG based on my referral and the reasons that I gave. That's not unusual. The coordination between the child psychiatrist at the clinic and the HMO is a big problem. We've had a lot of issues recently about continuum of care. AB 3632 was defunded by our governor, Arnold Schwarzenegger. At that time, we had a good relationship with the school district. If we had a child that needed out-of-home placement, it could be obtained using AB 3632 in the IEP process. That's no longer happening in my experience. The schools are now responsible for all of that, for placement of kids in residential facilities through the IEP process. When that doesn't happen, the child has very few options other than to be made a ward of the court or a dependent of the court, and the parents lose responsibility for their child, and that's just wrong. I've had situations where kids were in the hospital and we could not get placement for them in an appropriate place, and we had to tell the parents to abandon the child at the receiving home. Which many did. They were threatened, of course, by social services with being arrested, but that never happened as far as I know.
And just to clarify, AB 3632,
Right, there's an audit going on right now.
can you just quickly describe what that?
Oh, AB 3632 was the legislation that, for all special education children, that mandated that the IEP process would essentially allow for a sharing of responsibility for the children between the community mental health center and the school district.
Okay.
Now the responsibility for the mental health needs of that children for education rests entirely with the school district. So mental health has been taken out. There was a sharing of monies to make those things happen, and that's not happening at this point as far as I know. Or there was some overlap. I hope that's helpful. Okay. I heard what my friend here was saying, and I think you need a continuum of care in child mental health. You need it all. One kid is going to go from the crisis clinic to the hospital, to the residential facility, back home, to outpatient treatment. If one of those pieces isn't there, the child's going to fall through the cracks, and the services just won't be helpful to the families and to the children. So I think that's very important. Let's see. The other thing that I wanted to mention was that was record keeping. It's very important, particularly with foster children. I remember being here at a conference in 1988 saying how we needed a mental health record for foster children. It never happened. It still hasn't happened. Maybe now we can do it because it's a technical issue. We desperately need to have a mental health passport or mental health record for a child brought by a social services person into a community mental health clinic, because otherwise we don't know if the child's been hospitalized previously. We don't know what the previous medications were. We don't know what trauma the child suffered prior to coming into our community mental health clinic. The social worker should know those things, but often the social worker doesn't accompany the child to a psychiatric evaluation. The foster parent obviously doesn't know those things. we have to have a way to make that happen, and there's no reason why it shouldn't happen. So that's a very important issue, I think, and a problem in our system. So I'll stop there.
Thank you. Thank you so very much. Believe me, I've met foster children who come in with new foster parents. If I'm fortunate, I've actually taken care of the foster child before, and I happen to know their records better than the new foster parent. And
same
certainly when it comes to
experience
mental
in my-
health, yeah, you're sitting there and you're like, this is all they gave me, right? And you're like, okay, I'm trying to figure out what to do there. So actually, I guess my first question is for Dr. Baylor, in terms of, because you talked about, so you had all these funding streams that go to the county, right? And then the county certainly understand about local control and identifying what the priorities for the county. Then you say that the state agency does an annual review, oversight, monitoring, and you're developing this dashboard and so forth. When it comes to the dashboard, are you creating specific measures around children and children with special needs? Sometimes they have different needs than the adults. Are you, I mean, what kind of measures are you, I realize you're in the process of doing this, but I was like wondering, it's like, what kind of measures are you looking at, and is there, and particularly related to children with special needs?
Sure. We're doing a huge undertaking called the Performance Outcome System for just children, and we have a huge group of subject matter experts that have been meeting on a regular basis, and they've come up with a huge list of all the different measures that they want us to be able to collect, and we're trying to figure out which ones are we can easily collect, and what's going to take some more work. So that's an ongoing process. And then we also do reports on the performance outcome system to the legislature, and we're happy to provide those to you as well on the implementation of our performance outcome system.
And I know that you're undergoing this development of these dashboards, but as sort of a subset potentially of that work, or a small, tiny bit, would the department be willing to help out? We were trying to create a dashboard or report card for children with special needs under mental health components to maybe, through the work that you're already doing, extract a few measures that we could use in that way to be able to give us a picture of children with special needs overall.
Absolutely. I think at least from the specialty mental health side, and hopefully soon from the substance use disorder side, that will be part of our performance outcome system, where we'll be able to have data that is posted on the website so that you could have access to that.
Okay. All right. That'd be
Coming
great.
soon to,
I would very much looking forward to it. And as someone who did health services research, I know how tempting it is for people to add ever more new additional measures. So I know you're trying to keep them in control here. The other question I have, I guess, particularly, perhaps Dr. Rooney, you can more address this since at the county level. So how's the interface between the county mental health system and well, you also touched on this as well, Dr. Teal, in terms and schools and special ed. I mean, I know as a school physician, there are a lot of children with behavioral issues that then impact their ability to perform at school. They have, they try to get sometimes they may get mental health services through the school. In fact, sometimes that's been the only way I've been able to get help for some of the kids, usually not on the severe side, but on the more mild to moderate side. And I understand what you've talked about, problems trying to get mental health networks, and sometimes through their health insurance, but sometimes then I go through the school, and I'm sure the special ed people later on in the panel will maybe talk about what problems that may cause them. But how does county mental health interface with the school, and also how does that in terms of funding streams as well? Because, and I'm sure we'll hear from the special ed folks in terms of how education funding then goes to address things that are in the IEP. So can you maybe speak from your perspective, from the mental health perspective, and this interface between school and mental health needs that in school versus obviously they're tied to larger to the ongoing mental health needs in the community at home?
There's variability among counties. In my county, we are the provider, so we provide school-based services at all campuses.
Okay.
It's primarily funded through EPSDT, but also through Mental Health Service Act funding. We have a program that Schools First that involves these services on the campuses. So I'm a big believer in school-based and services in regard to the continuum of care. It sometimes is the place where we first engage people having behavior problems, et cetera. And in a county like mine, there's a high percentage of Medi-Cal beneficiaries, not necessarily so in another county, so they have to find other mechanisms for funding.
Just to add that to that, there's something called a SELPA, Special Education in charge of,
plan,
yeah. And each county is different, so there are 50, how many counties? 54 different counties?
58.
58, I was close. And each one is different. And so when we lost AB 3632, we lost a unifying force. Now each SELPA runs their own show.
And so just actually, Dr. Rooney, you mentioned, and you said in Colusa County, it's through the county mental health system. Do you get any funding from the education system for any piece of what you do, or is it all completely through, you said APSDT and so
Not
forth?
currently. I inherited a system there that is not a shared funding, but we do have the opportunity through EPSDT to match funding if we're going to move in that direction. So there's a possibility for expanding services that yet has to be tapped in my county. In many counties where there are provider networks, that's the major mechanism. The mental health director will say, give me 50 cents and I'll make it $1 in terms of EPSDT funding. So that's the way it is financed in many counties throughout the state. I would just mention that most counties, every county has at least one SELPA. Most counties have multiple SELPAs, especially population centers can have 8, 9, 10 SELPAs. So it gets rather complicated. However, education, in my experience, is a good partner with mental health, especially when we design these systems that mutually support one another's goals.
And just to loop back to the previous panel, what about interactions with CCS? I'm sure that some of these children, they may have significant medical needs, but that then leads to significant stresses at home and so forth. How often do you interface, or frequently do you interface with the CCS coordinators and so forth?
In my experience in larger counties, the family therapy is the main component or service that's valuable for those children that are in that system and families that are in that system.
In
Yeah.
Sacramento County, I can never recall interfacing with CCS.
Oh, that's
I
interesting.
did interface with them when I was providing services at Juvenile Hall.
Okay. Yeah, I did make note, Director Kent mentioned that only 3%, now, it just could be because the physical health is so expensive, but I wonder, is that the right amount? I mean, not that, always looking to spend more, but the question is there an unmet need that we're talking about? I just know that
I think
there's.
it would be terrific if we could do more.
Okay, well, certainly, yeah.
As a parent of a special needs child, I would say that it's definitely an area of concern and need.
Yeah, okay, yeah, I think it'd be good to explore that. So, okay, well, I want to thank all of you for your presentations, and be very interested, again, following up particularly on the work that the DHCS is doing on your evaluation, your monitoring and so forth, the dashboard, and also looking at, again, we're looking at trying to figure out how some of these interfaces that each of you brought up. And to me, I think often when we talk about children with special needs, mental health sometimes gets sort of put aside. People don't talk about the mental health part, and I certainly know, working with families with special needs, that mental health is certainly a very important component of the supports that both the patient and the child and the family need. So I appreciate you sharing what you today. So thank you. Thanks very much.
Thank you.
Look forward to working with you. Thank you. Okay, so our next panel is on developmental health services and programs. We have John Doyle, Chief Deputy Director of the Department of Developmental Services, Rick Rollins, Legislative Advisor for the Association of Regional Center Agencies, both here. So welcome, and thank you so much for being here. And perhaps we'll start with Mr. Doyle from the Developmental Services. Welcome.
Hi, good afternoon. I'm actually Brian Winfield, Acting Deputy Director for the Developmental Services.
All right, well, welcome, Ms.
Filling in for
Winfield.
Mr. Doyle. Thank you for the opportunity to present today. So in terms of an overview of our system, in California, we're fortunate to have a system of entitlement for individuals with developmental disabilities. For individuals in California with developmental disabilities, we have a system of entitlement, which means that individuals who qualify for services receive services through the regional center system. The developmental disabilities are defined as intellectual disabilities, autism, epilepsy, cerebral palsy, and other disabilities which require the same or similar services of individuals with intellectual disabilities. To qualify for services, an individual must have a disability which originates prior to age 18, is expected to be lifelong, and is a substantial handicap for that individual. And as I said before, the case management that regional centers provide is an entitlement and continues throughout their lifetime. The department contracts with 21 private nonprofit regional centers throughout the state of California to provide services to individuals with developmental disabilities and their families. These services include intake and assessment, case management, advocacy, assistance with referral to other assistance programs, as well as funding services through the regional center themselves. As of September 2015, regional centers were serving approximately 135,000 children and youth. And in collaboration with the families, regional center case managers who are assigned to each of the families assist them in developing the individual family service plan for individuals under age 3 or the individual program plan for individuals who are age 3 and over. Through this IFSP or IPP, it delineates the needs of the family and the individual and the types of services that will be provided, including the case management, the advocacy, and the purchase of necessary services for this individual. For individuals who are under age 3, the regional centers provide early intervention services, and these are intensive services provided typically within the family home, and they're meant to help ameliorate the social, mental, and physical well-being of the individual. Some of the other services that regional centers might assist with coordinating and purchasing are medical, social welfare, adaptive equipment, and whatever the unique needs of that individual are to help that person to remain in the family home. Once an individual becomes school age, however, the education system becomes the primary provider of services, and the regional center is there to continue to provide case management, coordinate services, and to assist the family. In terms of funding for our services, for funding for regional center services, approximately 58% is state general fund and 42% is federal funding. That in current year, that equates to $2.78 billion in state funding and $1.97 billion in federal funds. The federal fund source is Medicaid, which includes the Home and Community-Based Services Waiver, as well as the 1959 State Plan Amendment funds, as well as Title 20 TANF funds. These federal programs require that the state share in the cost of services using state funds. Additionally, the department receives a couple of major grants from the federal government. One is the education grant to help fund the Early Start program for children under age 3, and the social services block grant under Title 20 of the Social Security Act. The Department of Developmental Services distributes the funding to regional centers based on eligible expenditures, and then regional centers use that funding to purchase and provide services through their individual vendors for consumers and families. Regarding the state and local coordination, our department engages in a number of activities with other state departments and agencies that provide services to individuals with developmental disabilities. A couple of examples are the Interagency Coordinating Council for Early Intervention that includes representatives from the Department of Healthcare Services, Department of Social Services, and the Department of Education. The Interagency Coordinating Council also includes service providers, family members, and other community representatives so that we can receive a broad perspective and also receive as much advice as possible on the administration of the program. Another collaboration through the Department of Healthcare Services, a current example, is with the current transition of behavioral health treatment services for individuals under age 21, whereas regional centers are currently funding that. It will become a Medi-Cal benefit, and those services will transition over to DHCS. And the goal of working with DHCS is to ensure that there's a smooth transition and that there's a seamless transition for families so that they don't necessarily have any interruption in services. So while the state level coordination is very important, the most important piece is the local coordination through the regional centers as the case managers help families navigate the system and help them to obtain the services that they need. Thank you.
Hey, thank you. So, okay, Mr. Rollins, since he talked about how the regional centers actually do all the work.
Do I get to talk about how DDS works? Yeah, thank you, Dr. Pan and distinguished staff. Thank you so much for the opportunity to testify today, and thank you for convening this important hearing. We look forward to working with you in the next year. My name is Rick Rollins. I'm the legislative advisor for the Association of Regional Center Agencies, ARCA. I'm also the father of a 25-year-old son with autism who's been served by the regional center system since 1992. And for you, Senator Pan, I know one of your pride and joys of your district is the Mind Institute at UC Davis, and I'm a founding founder of the Mind Institute, as well as working here in the legislature for 24 years as Secretary of Senate and a number of other positions in my over 40 years of work here at the Capitol. You've asked us to testify on a number of subject areas, including the function of ARCA, an overview of regional center services for children and youth, the funding structure and distribution for developmental services, and current challenges and barriers facing the system. We've submitted a 12-page written testimony to you for your review. We hope it will be helpful not only for this hearing, but any future hearings that you have on this subject. It's a lot to digest in five minutes of testimony, and hopefully the 12 pages of work that was put into it will be helpful to you in the future. California's community-based developmental services system dates back to the late 1960s. At that time, parents of children with intellectual disabilities and developmental disabilities wanted an option to institutional care. The 21 not-for-profit regional centers were formed to meet the needs of individuals with developmental disabilities in the community. And Brian has already iterated the eligibility-based system that we have. That is, you can have a developmental disability in California but not be eligible for regional center services. Since we haven't expanded the definition of what is a developmental disability in our state statute since 1971, there are many conditions that go uncovered in our system. The regional centers have three primary goals: help infants and toddlers to catch up to their peers, help children to stay with their parents at home, and help adults with developmental disabilities to be as independent as possible. The function of ARCA, the Association of Regional Center Agencies, we represent the 21 regional centers and support them to achieve their mission through legislation, the state budget process, and coordination of a variety of statewide projects. ARCA's role is to provide communication, education, and training to regional centers throughout the state regarding statewide and federal developments and trends. The overview of the regional center services for children and youth was explained by Brian, but again, we're serving close to 290,000 individuals and their families. That number based, of course, grows every day in our system. This is an eligibility base, but it's also an entitlement program. So once someone is found eligible for services, unless the condition goes away, that person is entitled under California law to services for the rest of their life. So unlike the education system where we have a waxing and waning of populations, once you're in the developmental disability system like my son, he will be there from the time he was diagnosed at 22 months with autism to the day that he passes away. We serve currently 135,000 children, as was mentioned. About 98% of those children live at home with their families, and at a cost of roughly $500 million or so annually. And Brian did a nice job of explaining the funding stream of how our system is funded. Regional centers provide direct services to individuals and families through the assessment, evaluation, and case management services and planning of services as well. It's important to note that our system under law is required to seek out generic services first before providing the services directly. And that's an important part of our system in that we rely heavily on things like Medi-Cal and CCS and a number of the other programs that were presented today before your committee before regional centers step up and pay for those services. These generic services, as with the regional centers, have undergone tremendous budget reductions over the years, and the whole safety net of the programs that we rely on, particularly for children's programs, have really been impacted by these budget cuts. For children's programs, primarily the services that we provide are behavioral services, mostly ABA, Applied Behavioral Analysis for kids with autism, also respite programs, and infant programs. And I'd just like to mention quickly that as part of the Regional Center's charge is the Early Start Program, which unfortunately during the Great Recession of a few years ago, it was decided to eliminate the Early Start Program, but I'm pleased to report to you that this legislature, and I know you supported that legislation as well, to restore Early Start, a very critical program for 0 to 3 kids, very dedicated staff at the Regional Center that provides services, and the direct services by the service providers in our community that really are the backbone of providing services, not only to children, but to others as well. You asked briefly to touch upon the current challenges and barriers facing our system. The developmental services system has been grossly underfunded really for decades, but this problem really got worse during the recent Great Recession, with the system sustaining over $1 billion in cuts, and also a lot of very nasty trailer bill language that was adopted that cut programs. And I use the example of Early Start as probably the most egregious of all the programs that were impacted during those cuts. We need to restore this system to a level of where it needs to be. We at ARCA are proud members of the Lanterman Coalition, which is undertaking an initiative this session that I know you've heard a little bit about over the last few months, and we strongly urge the legislature and the governor to support stabilizing this system with a 10% increase immediately, increasing funding on an annual basis of 5% until reform is achieved. And probably the most important thing, we don't want anyone to believe that throwing a 10% increase to this system is going to fix all of the ills of the system. This is really a triage problem that we have now, with so many of our service providers throughout the system going out of business, programs not being developed, and particularly in children's programs and other special populations dealing with the autism epidemic as we are as a state and as a country. There's a great need to really take a look at this system and reform the way that we provide rates and support to regional centers. Thank you, sir.